everybody. This is again on behalf of Dr. Finelli, who is not here, but Dr. Krishnan asked me to give this talk. So I don't have any disclosures, unlike Dr. Finelli, who has a few disclosures here. But the main concept of this is we know that SFA CTOs are complex lesions, and generally, these are successful in crossing about 70% of the time. The barriers to crossing CTOs is really the length of the lesion and the amount of calcification. So if the lesion is greater than 100 millimeters, it's oftentimes difficult to cross, as well as if there's significant calcification at the distal cap. Within 10 millimeters, it's often difficult to cross. There's two approaches, as you've kind of learned throughout here. One is the intraluminal approach, where you go in the proximal vessel, and then you go through the CTO in an intraluminal fashion and enter into the distal cap. And then the second is the subintimal approach, where you're going from the proximal vessel through between the intima and the media, and then cross the CTO and the subintimal, and then re-enter into the distal cap. And so really, the question is there any difference in terms of approaching it in an intraluminal approach versus a subintimal approach? So really, the data is very scarce out there to answer that question. And one of the trials that was the Impact Global study, that is a large trial that had one cohort of patients that looked at this question. And so this was, I think most of you are probably familiar with this trial. This was a prospective trial, multi-center international trial, single arm, that basically looked at paclitaxel DCB for the effectiveness of treatment of femoral popliteal lesions. And the main thing that I want to point out is, obviously this is the trial design, but one cohort, which is down here, as you can see, of 126 patients, looked at CTOs of greater than 5 centimeters and treated with DCBs and with either the intraluminal or subintimal approach. And so based on this trial, you can see that 92% of these CTOs were de novo lesions. There was mainly involving the SFA, and you can see the lesion length was about 22 centimeters, 22 centimeters with an occlusion length of around 11 centimeters. There was calcification in about 70% of these patients. About 2.2 DCBs were used for a total length of about 23 centimeters, and then provisional stenting was performed in about 46% of these patients. You can see the device success rate as well as the procedural success rate, and the clinical success was good. And so this was really the findings of the trial. So this is the primary patency at 12 months. And what you can see is that the red line here is intraluminal crossing, and the blue line here is subintimal crossing. And what you see here is that the intraluminal crossing had a primary patency of about 90% versus 79%. So there was a trend towards better outcome for the intraluminal crossing. However, as you can see, that the p-value here is 0.18, so it was not found to be statistically significant. Here's the freedom from clinically derived TLR. And again, similar findings where the intraluminal crossing was 92%, freedom from TLR was 92%, and the subintimal crossing was 86%. But again, there's a trend towards better for intraluminal crossing. However, again, not statistically significant based on our p-value. So the 12-month safety outcomes showed that DCBs were fairly safe at 12 months. The primary safety endpoints were met at 89%. And then when comparing the subintimal and intraluminal approaches, the major adverse events were 17% versus 14%, so not terribly different. So in conclusion, this was a good trial that basically showed that DCBs are safe for CTOs, There is some trend in terms of interluminal crossing being having better primary patency and TLR compared to subintimal crossing, but however, this is not found to be statistically significant. And this is similar to a prior stent, drug-eluting stent study, the Zephyr trial, which looks at Zilver stents in CTOs, and they basically looked at subintimal versus interluminal crossing and deployment of that stent. And again, what they found was that the interluminal crossing had a restenosis rate of about 35% at 1 year versus the subintimal approach had about a 40% restenosis rate at 1 year, however, also not statistically significant. So again, we're seeing some indicators that this is something that we really need to look at. I think more data is really needed, but right now, based on this, we cannot make a generalization about interluminal being better than subintimal. So, thank you.